Okay, greetings everyone. I'm Silvia Selesh, your host for this webinar. Thank you for attending this session entitled Geriatric Surgery, the State of the Art. This webinar is being recorded and will be made available as soon as possible. A few words about our company. MDPI is an open access publishing company. We supported academic communities since 1996. We are based in Basel, in Switzerland, and our mission is to foster open scientific exchange in all forms. We have over 422 diverse open access journals, peer-reviewed journals, and conference journals. Our Journal of Clinical Medicine is international peer-reviewed open access journal on clinical and preclinical research. We publish article types, including research papers, reviews, editorials, communications, etc. If any of you are interested in submitting a paper to our journal, you can contact us for more information. Today's webinar is composed of 5 speakers. Our 2 chairs are Professor Fausto Catena, together with Dr. Belinda De Simone. First, we will have our chairs introduce the webinar and speakers, follow up with our speakers' presentations and Q&A session at the end. Please indicate which speaker your questions are directed to and leave your questions at the Q&A box beside the chat. This webinar is based on a special issue of the same name, where the guest editor is our chair, Professor Fausto Catena. And now, a brief introduction to our chairs. First, we have Professor Fausto Catena. He completed his degree in medicine and surgery at the University in Bologna, where he also received his PhD degree. From 2000 to 2011, he was a consultant general surgeon at the Department of General Emergency and Transplant Surgery and at St. Ursula Malfigi University Hospital in Bologna. He has been a fellow of the Royal College of Surgeons since 2012. In 2013, he received the Italian National Certification as full professor of general surgery. From 2012 to 2020, he was a chief of the Department of Emergency Surgery and General Surgery at Parma University. And since 2021, he has been the chief of the Department of General Emergency Surgery at Bufalini Hospital in Cesena. Professor Catena has written more than 800 scientific papers, 40 book chapters, and 5 books. He won 20 national and international scientific prizes, and he has performed more than 2,000 medium-high level surgical procedures. Professor Catena is editor-in-chief of the World Journal of Emergency Surgery and is the editor-in-chief of more than 10 other journals. As for our Dr. Belinda De Simone, she graduated in medicine and surgery at the University Sapienza in Rome. She moved to Parma to accomplish her dream to become a visceral surgeon at the University of Parma. There she observed her mentor, Professor Fausto Catena, who trained her. Following his advice, she left Italy and went to Paris to be educated by one of the best minimally invasive surgeons, an expert in bariatric surgical procedures, Professor Chouillard. I hope I'm pronouncing it correctly. She joined the World Society of Emergency Surgery Board in 2022. She is responsible for scientific research from 2020 to 2023 at Poissy and Saint-Germain hospitals and was the principal investigator for international observational study focused on management of severe cholecystitis during the COVID-19. And also she was part of the many scientific projects. Thank you to both chairs and all speakers for agreeing to participate at this webinar. Without further ado, I give the floor to our chairs.
Thank you very much, Silvia. Thank you for the invitation for this webinar. The topic is a very strong topic and a very hard topic. And the speakers are strong and hard as well. Geriatric surgery is the present, but will be the majority, the most part of our future. We perform a geriatric surgery in the majority of our activities, and it is a very difficult environment. As a matter of fact, we have to deal with very difficult patients with a lot of comorbidities. In many cases, they are high surgical risk patients, and we have to solve many issues because they are a totally different population. So we have to think about their disease, so their main disease, their surgical disease. We have to think also about their comorbidities, but we have to think also about their life expectancy. So we have to perform a sort of balancing of these different issues and to create a sort of coordinated decisions with the best evaluation for the lives of these subjects. We cannot do this alone. We have to do it with the collaboration of many other specialties, but at the end, it is the surgeon, the last person that have to decide. And in many cases, it is a very difficult decision. So it is very important to have informations about which is the best of the knowledge to deal with these patients, and this has to be done for emergency general surgery, but also for general surgery. Doing this, we will be able to give to our patients the best of the knowledge and the best of diagnosis and treatments. So we decided to do this webinar with a focus on geriatric surgery, and the majority of lectures will be on emergency general surgery, so the most difficult part. But as you will see, the information, the take-home messages that you will have in the emergency general surgery will be translated in general surgery as well. I think we can start with the first lecture. The first lecture is from my co-chair, Dr. Bellina De Simone. And it is about one of the most hot issues, hot topics, that is trauma, so geriatric trauma. WSES was able to develop a consensus conference with guidelines about it, and this was presented in the last Congress in Pisa the last month. And as you can see, this is a huge work with many recommendations, but Dr. Simone will be very good to present it in only 20 minutes, we hope. And you will have a lot of information about this difficult part of management of patients, of traumatic patients, that they are geriatric patients. Please, Dr. De Simone, the stage is yours.
Thank you, Professor Catena. Yes, I trained to be very short. So I'm very happy to be here to present this huge work that we did. And I want to thank you to all the colleagues and friends that collaborate with me to finalize this big project, and I'm proud of this. So I will present this work. The WSES guideline about the geriatric trauma management, some information before entering the heart of the problem. The geriatric patient and elderly patient will represent a big part of the population in developing world, and maybe in 2050 elderly people are expected to make up more than 21% of the population and almost 39% of trauma admission. And the oldest old patient will increase in the next year. And trauma is the 5th leading cause of death when old age group are represented. So this is a big problem for health system organization, and some key critical issues are most important in our practice, because advancing age is associated with physiological change in most of organ system. Age over 65 years is an independent risk factor for increased negative outcomes after admission for trauma, without distinction of injury severity score. Increasing age is an independent predictor of poor outcome for trauma, and there is a high under-3 rate among elderly injured patients. But why? So we decided to develop this topic and guideline. We individuated the most research area, with the PICO criteria, and the WSES steering committee approved 6 research topics and 17 PICO questions. All the literature assessed was evaluated with the GRADE methodology, and the principal coordinator supervised every step of this work. So this is the table that summarizes the main topics and the PICO question. We will start with the definition, the primary evaluation assessment of the patient, resuscitative time, oral anticoagulants management, antibiotic analgesia and antithrombotic prophylaxis, and the management of the end of life in trauma setting. But the first main topic is to define the older trauma patients. This study declared that trauma patients older than 55 years old have to be considered for inclusion in geriatric trauma protocol. So we suggest an early trauma protocol activation in patient aged 55 and over. This is a weak recommendation based on a low level of evidence, but we recommend to carefully evaluate injured patient age 55 years old and over for the high risk of mortality and avoid under-3 age. This is a strong recommendation. Why? Because the mechanism of trauma is soft in elderly patients, because the most cause of admission is a ground level fall, but mortality rate is higher compared with the youngers, because of advanced pre-existing medical condition, frailty, and poor physiologic reserve. So what we have to assess in this patient? First of all, we have not to discuss that at the admission, we have to require a CT scan with the contrast enhanced administration. This is mandatory. We can discuss that because high level of creatininemia is not a contraindication to administer contrast in this group of patients. So what we have to consider is the new physiology of this patient, because aging is correlated with change in organ system, in the brain, in cardiovascular system, and in the global body world. A chronological age is not physiological age. What we have to consider is the frailty syndrome in this patient, because frailty is the vulnerability of the patient correlated with a lower response to the stress, the surgical stress, the trauma stress that is correlated and physiological with the aging. And frailty index is a strong predictor of outcomes after emergency surgery and trauma. So, the primary assessment of the patient, we suggest an early and rapid assessment of the patient, of the mechanism of injury severity score, of vital sign, and on frailty, including comorbidities, medication history, to identify vulnerable trauma patients at higher risk for negative outcomes after trauma. This is a weak recommendation, but it's very important. We recommend assessing frailty in all elderly trauma patients as a factor correlating with aging. Why? Because vital parameters are not the same than in younger. In elderly people, we have to consider, and it is most important, the role of medication on the physiology of this patient. So when we admit a patient for trauma, we have to consider that mortality increases when the blood pressure is inferior to 110 millimeter of mercury, and when the heart rate is superior of 90. Why? This is always about physiology of aging, because tachycardia and hypotension are often lacking in these patients that are most chronic, are most presenting chronic hypertension and decreased sensitivity of myocardium to circulating catecholamines. And we have to consider the polypharmacy, because patients over 55 have chronic comorbidities to treat, and often these patients are treated with beta blockers and other antihypertensive medication, anticoagulants and antiplatelet agents, steroids, antipsychotics, and sometimes glaucoma treatment that will alter our clinical assessment. So some researchers try to define hypotension according to age, and they conclude that hypotension was a value of 85 millimeter of mercury in the group of patients aged 1835, was 60 millimeter of mercury in patient aged 36-64, and was 117 millimeter of mercury in patient aged over 64. year-olds. So we recommend keeping a lower threshold for trauma patient, for trauma protocol activation in geriatric patient, with 3 age set points of 90 heart rate, BPM, and systolic blood pressure less than 110 millimeter of mercury. This is a strong recommendation. We have to consider also that elderly patients are patients that are used to be in an occult hypoperfusion after trauma. So we can use the normal parameter to evaluate this condition. And the best definition of occult hypoperfusion in trauma patient are to found lactate over 2 millimole, base excess inferior to 3 millimole per liter, and a blood pressure of over 90 millimeter of mercury, and heart rate inferior to 120 BPM. But this occult hypoperfusion is correlated with a high mortality in this group of patients. So our first and not with the other issue is to perform an early blood gas analysis for this patient to assess the baseline base deficit and lactic acid assessment in geriatric trauma patient to investigate as soon as possible this occult hypoperfusion of organs. Why? Because we have to pass to very rapid at the phase of resuscitation, and we have to decide if vasopressor are needed in this patient. In this case is a geriatric patient, but we have to know that the resuscitation is not the same in the elderly patient, but we have to consider that the first phase of a shock in this patient is the same. So we have the first phase where we have a high release of noradrenaline, and the second phase where we have a high release of vasopressin. But how we can use vasopressor in this patient? We have to be careful because elderly patients have an high plasma noradrenaline release with higher injury severity score. This is have to be considered because norepinephrine and vasopressin have a different role for this patient, and the impact of the early administration of vasopressin in low dose can reduce mortality in this group associated with a good fluid administration. So we recommend that every trauma center provide meticulous triage to recognize the need to early activate resuscitative protocols for elderly patient. These triaging criteria should include physical examination, vital sign parameter, gas analysis, and medical history, emphasizing to clinical condition, medical history to guide resuscitative therapies, early coagulative support, and the need to correct coagulopathies. We recommend also rapid recognition and correction of coagulation disorders in this group of patients. Be careful. We can recommend to be very careful in administer vasopressor in patient that will present hypotension after trauma. We recommend to implement permissive hypotension in selected elderly trauma patient presenting with hemorrhagic shock without intracranial lesion. What about delirium and this group of patients? Delirium, there are not focused papers in the trauma setting and emergency setting, but we can say that advanced age and dementia are predisposing factor risk to delirium in this group of patients, and where we can act, where we can have a role as an emergency surgeon is to modify our type of surgery to decrease intraoperative blood loss or transfusion and to control the intraoperative hemodynamics of this group of frail patients. What about the management of direct oral anticoagulants? Yes, we have several evidence-based and opinion of expert guideline, but for this particular group of patients, we recommend performing routinely the common coagulation test in elderly patients, including the activated partial thromboplastin time, thrombin time, and here and hair and anti-10A levels to assess early anticoagulants exposure in this trauma patient, because TAG or ROTEM are not so useful to assess the coagulative profile of this patient. Strong recommendation. So if there is a trace of active anticoagulants in the blood of patient, we have to proceed with reversal, to administrate reversal agent. We recommend not to proceed to reversal protocol in this patient only because they are elderly. What about the use of antibiotics? Antibiotic prophylaxis is important in the penetrating and blunt trauma. We recommend antibiotic prophylaxis in penetrating abdominal and thoracic trauma, in severely burned patient, and in open fracture patient to decrease septic complication. We recommend early empiric antibiotic therapy in patients presenting signs of sepsis and septic shock, and high-risk patients that are patients presenting obesity, immunocompromised, and high ASA score. That will be admitted for penetrating abdominal trauma to avoid surgical site infection and peritonitis. We recommend against the administration of antibiotics in blunt trauma in absence of sign of sepsis and septic shock. This is a strong recommendation. What about pain control? This is most important for all patients, above all in this group of elderly patients, because we have to avoid all the negative side effects of high administration of opioids. So we recommend a regular administration of intravenous paracetamol every 6 hours as first-line treatment to treat acute trauma pain in elderly in a multimodal analgesic protocol. What is important is to reduce the use of opioids. So paracetamol is effective, combined with other medication that are not so bad in this patient. And we have to implement peripheral nerve blocks to avoid pain in this patient. So what we have to consider is the use of epidural or spinal analgesia, and we recommend carefully evaluating the use of neuroaxial blocks for this patient, with a focus attention to patients that are that have anticoagulants, that are treated with anticoagulants. What about the thromboprophylaxis? When and how? We recommend administering venous thromboembolism prophylaxis in this patient as soon as possible, evaluating the risk of bleeding and the thrombogenic risk. If pharmacological prophylaxis is not possible, we recommend mechanical prophylaxis in this group of patients. We recommend also to discuss in a multidisciplinary approach what is considered futility in this in the management of a trauma patient that we consider severe in this progression. So the multidisciplinary approach is more important. The decision, sharing the decision with the patient, consider the patient directives and family feelings is more important to take the patient to the end of life. We recommend involving as soon as possible the palliative team in managing an elderly injured patient in the trauma setting. So I try to be very short and synthetic, but I hope to be essential in my presentation and recommendation. Some take-home message: the management of elderly trauma patients require knowledge of physiology of aging. Aging is correlated with frailty, and frailty is a risk factor for elderly trauma patients. Focused triage and early activation of trauma protocol can improve outcomes, and geriatric ICU are needed to care for elderly trauma patients in a multidisciplinary approach. A kind reminder, so join the Colder project. This is a new study of the WSCS, the management of complicated colorectal cancer in older patients, age over 75. You can find my mail and the mail to have information for this study. Thank you very much for your attention. Thank you. Sorry. Thank you very much.
Thank you, Dr. De Simone, for the nice presentation. There are not questions in the chat, so I have a question for you, and it is about the age and the cutoff for the referral to a level 1 trauma center. So the question is, do you think that the age alone in a major trauma is a factor for a direct centralization to a level 1 trauma center?
Yes,
and
I think.
If your answer is yes, which is the cutoff of this age? Because I am 51 years old, and maybe I also have to be referred to a level 1 trauma center if I am defined old, if I have a major trauma.
So thank you for the question. Is very focused because I talk about this in definition. Age is not advanced age is not a predictor of mortality, but age over 55 is an alarm to consider the early activation of a trauma protocol. So yes, we have to admit the patient over 55 in a one-level trauma center.
So I am under 55 cutoff age. Okay, thank you very much. I give you the baton if you want to introduce the next speakers.
Okay, so I will introduce the next speaker. Is Dr. Brian Tian, and he will present the assessing and managing frailty in emergency laparotomies, a WSES position paper. Only 2 words for his activity. Brian Tian is an acute care surgeon, and he worked in the Singapore General Hospital and the National Cancer Center in Singapore. Singapore General Hospital is ranked as one of the world's top 10 hospitals by Newsweek. He is specialized in acute care and gastrointestinal surgeries. Dr. Tian teaches at the Duke Graduate Medical Schools, and is also on the editorial board of several journals. So it's very young. Let's start with your presentation. Nice to meet you.
Nice to meet you. Thank you for the introduction. Wow, I'm actually not that young, but okay, thank you for that compliment. Okay, I'm going to start. My topic today can be a little bit dry.
It's a compliment. It's not to.
No,
okay.
I like it. Thank you for the compliment. So yeah, right. I'm from Singapore, and currently I'm doing a fellowship in Italy to learn a bit more about minimally invasive methods in acute care surgery and a bit of colorectal. So that's why I met Prof. Catena. I'm going to present a paper, and this was very much his brainchild, and I'm just given a nice chance to work on it. So the paper is called Assessing and Managing Frailty in Emergency Laparotomy. It's a position paper that was just recently published. So my name is there, but there's like about 35, 40 authors. Okay, so this is the paper that was published. And again, I thank Prof. Catena for giving me the chance. And most of the people here, their names are there as well. Okay, so I'm going to take this paper, which is actually really long and lengthy. And we're just going to talk about the salient points, mostly the recommendations. So first, the background. In the real paper is very long, but the essence of it is that around the world, we are all getting old. And the population around the world continues to age. Western countries, Eastern countries, everyone's aging as well. And invariably, as surgeons, we are going to encounter more and more old patients, and we need to know how to handle them. And we must always remember, even though we're all old, or we are getting older, not all old people are the same. Look at these two. They're entirely different. The guy on the left, 60 years old, looks great, probably going to win some award for Sexy Grandpa of the Year. The guy on the right, also 60 years old, looks terrible. You and I know if they both present with peritonitis today in the emergency department, they might and most likely are going to have very different outcomes. So you can see that age alone is not just enough to determine the potential outcomes of someone, because they can be physiologically very different. The comorbidities, the lifestyle, everything is different. So you expect them to have different outcomes. And so the aim of this paper really is to figure out how can we have a better system of assessing this and understanding that age is just a number. And this is what I'm going to bring us through today. So with this in mind, at the end of the day, there have been papers, and you don't need a paper. We all have anecdotal experience. If these two patients come in, we know the guy on the right, that very obese guy, is going to have a bad outcome. The guy on the left, the fit guy, is going to have a good outcome. So what really triggers in our mind? How do we decide whether someone's going to have a good outcome or a bad outcome? To this day, touch your heart as a specialist, you know, you're going to do the eyeball test. You're going to look at him. Oh my gosh, this guy's got diabetes, he's fat, he's obese, he's going to do poorly. And the eyeball test is what literally most of us do. Whether this paper written by Hubert shows it, or whether you know that that's what you do. And this is not enough, right? Because we need to have a more objective way of deciding. That's number one. And a more objective way of this, of figuring out that age is just a number. So there's this concept. Honestly, it's not been a new concept, but it's gathering speed and momentum. Even in my country as well, we literally just have a national clinical guidelines on frailty. So frailty is a big buzzword. What does it mean? Frailty ultimately means it is an age-related, but not age alone, age-related cumulative decline in multiple physiological systems. Okay, and it is proven across many disciplines. It is a better predictor of mortality and morbidity than chronological age alone. Unfortunately, there are currently more than 20 instruments out there in the literature, and each instrument has got many interpretations. But we know that this concept is what we must take into consideration when patients are coming in and we consider them old. And for all intent and purposes, that number is kind of ballparked at around 65 years old in international literature, but every country could be different. Okay, so the summary of our methods and materials, we got together a committee, we searched electronic databases, we put up anything that's related to frailty, emergency laparotomy, outcomes and all that. And we look for all the manuscripts from those dates written there with a lot of focus and preference given to RCTs, randomized trials, prospective studies. And case series of this, of course, not so much. Okay. All right. This was that, explaining the same thing. Okay. And ultimately, when the committee gets together and we analyze the so-called papers, ultimately, we use a great system, which is what the WSCS used to produce a lot of the recommendations. You can find this online. So, of course, I just want to bring your attention to like maybe 1A, 1C. Those are strong recommendation, high quality evidence. And 1C will be like strong recommendation, we feel is correct, but unfortunately, the evidence is low quality. So a lot of the recommendations are going to be toggling between 1A and 1C mostly. Because if it's a weak recommendation, well, they won't really be inside. In total, there are many things to look at, but for us, in this topic, there are about 12 recommendations overall. So recommendation 1, it can be very wordy, so you can just hear me speak. The main recommendation is that, very simple, all patients above 65 years old should have a routine frailty screening. And as I mentioned, there's many tools out there. The one we're going to advocate for is a clinical frailty scale, or CFS, and I'll touch base a little bit more about this. And those that classify as vulnerable must then go for a comprehensive geriatric assessment, a CGA. And of course, the CGA is better, but it's going to be very time consuming. And that's why usually you do a quick screen. And those that are maybe in trouble, you're going to do a more in-depth screen. Let's look at some of the key evidence, okay? So the CFS, a clinical frailty scale, of all the various screening instruments out there, and there are a lot, it's probably the most validated, especially in the realm of emergency laparotomy. The CGA is really the gold standard. It's the most comprehensive, but it's time consuming. By the time you're done with the CGA with a patient who's septic, the patient will be dead before you even get a score. And of course, we'll come back to two of the major studies of many studies out there. There's the ELF study, and then there's later a NILA audit. I'll show you that. So the ELF study, of course, proven that frailty and a 90-day mortality is definitely related and important. Okay, so why CFS? Firstly, the first two columns here show you that, as I mentioned, there are many tools out there, and a lot of the tools are very specific to different patient age and specific to different conditions. So when we look at trauma or emergency surgery, there aren't many. And there's one, the TSFI, there has been somewhat validated, but not popular. There's also the EGSFI, the Emergency General Surgery Specific Frailty Index. But really why we chose CFS is because of all the studies that we put together, the most important ones in our recent time comes from the NILA audit from the UK, and the ELF study that, again, I'll show you. And they basically validate the clinical frailty score of CFS. But bear in mind, the NILA actually used a CFS score of more than 5. And I'll show you this. Okay, so this is the CFS, or the clinical frailty scale. You can find this online, or you can take the slides. Essentially, most papers actually report the CFS above 4. I don't know if you can see my mouse, above 4 is vulnerable, and that's when you do the CGA. But bear in mind, the NILA audit takes it at actually mildly frail, then they do the CGA. So there's no real standardization yet. But we just say a CFS in your institution, 4 to 5, generally, you should do a CGA. Okay. And the CGA is really a very comprehensive assessment. It's got about 6 parameters, score of 30. And generally, anything 24 to 30 is considered good. Anything 24 is not so good. But the strict cutoff, people are deciding between 14 and 17 below means you are really frail, essentially. And the CGA problem is very good, very comprehensive, but takes a lot of time. So a lot of the studies recommend CGA within 72 hours. I'll touch base on this again. So bear this in mind, sidetrack later, for those who have some background in this, and maybe even more expert than me, you'll realize actually the CGA is also a very difficult topic because in itself, many hospitals around the world use different scoring system. Okay, but the NILA and the ELF use this 6-item 30-score index. Okay, so that's one. Recommendation one, everyone come in, should get a screen. Those who are vulnerable should go for a more comprehensive assessment. Okay, so recommendation 2, decisions regarding surgery should consider the patient's degree of frailty rather than age alone. And that's what we said, right? 2 patients, 80 also coming in, one so fit, one so obese, they're going to be different. So don't just look at the age, they should always consider frailty. And we'll build up on this topic as we go along. So why is it important to consider the clinical frailty score, right? I mean, as a surgeon, as I mentioned, you touch your heart, most of us come in, we do an eyeball test and we say, this guy's going to do well or bad. So why you want to do this score? Why it's so difficult? Firstly, we must admit, we are not God. No one of us, even though we can predict the fat guy on the right is going to die more than the skinny guy on the left, we really don't know. None of us can predict for certainty that what outcome is going to be. And therefore, we need more and more objective tools to help us in decision-making, whether to operate or not, and the counseling process as well. Okay. So I show you the ELF study. Basically, we're going to come back to this quite often. And now they have an ELF2 study. You can find this online. You can even join the study or donate if you want to. So the ELF study basically shows, as we expected, that frailty has a very bad outcome. The more frail you are, in fact, the degree of frailty is linearly related to mortality. So frailty is an important concept. The NILA audit, which is the other big recent study, this is from the UK, shows that, again, patients who 65 years and above, if they fall into the frail category, they have worse clinical outcomes. So these 2 studies validate frailty is important. Okay, and they show where you're frail, you have longer length of hospital stay, higher 30-day, 90-day mortality, higher hospital visits, and 30% have never returned to their own homes. They go to old folks' home. And we'll drill back on these points over and over again in this talk. But unfortunately, so what if the recommendation 1 tells us we should screen? Recommendation 2 says that now we know with the screening and the scores that some patients will do better than the others. But so what? It's something that we know, right? The truth is, as of now, and although we'll build more recommendations, there's no real way to intervene. The EPOC study is trying to figure out, is there a way to do this stepwise intervention, right? But we're still in the process of learning how best to utilize this data. So recommendation 3 is that now that we have screened patients, and we kind of know, okay, some patients are going to do better than the others, in addition to clinical parameters, right? Are they in shock, so on and so forth. So the treatment plans for frail older patients ultimately should align with goals of care and be based on a discussion regarding realistic outcomes. What this means is that basically, but in Italy, it's true, but especially in my country, it's absolutely true. When you come in and no matter even the patient's 100 years old, the children always want to save their parents, right? This is normal. It's human nature. Like even if you need to intubate, tracheostomy, do what you can, cut open the chest, save my mom and dad. But that's not realistic. So we know that if you're not only physiological status aside, if you're frail, your outcome is going to be bad. And sometimes it might be kinder to just maybe choose a conservative method. So ultimately, recommendation 3 suggests this discussion about goals is very important. You got to discuss with the patient, hopefully they're conscious, and with the family about really what is the anticipated longevity, the functional status, the outcome of going through an emergency surgery. It doesn't mean that you cure and things are good, and ultimately you can decide, because sometimes it might be just kinder to not do anything, right? Like a AAA severe rupture, they're so comorbid, or going through emergency bypass. I mean, these are just examples. Sometimes it's just kind of not to do it. So this discussion is very important. Recommendation 4 is that apart from understanding the process now, that we have a new tool in mind of how to screen patients, when to evaluate, and how to have a better sense on potential outcomes, we know that there are certain things we must do actively. This is something that I admit I don't do it, and I should, and we will do it. And that is that all frail older patients, once they identified as frail or vulnerable, they should have a routine preoperative cognitive assessment. Okay, what is this? Dementia and MCI. Okay, the prevalence of dementia is about 5%, and if in those 70 to 79, if you are above 90s, is 40%. Okay, but dementia is also very obvious to see. The family will tell you they forget their keys. You kind of know, right? But the problem is there's something called mild cognitive impairment, MCI. This is where it's mild. The family may not realize, the patient themselves don't know. And this is very prevalent. It's more than 50% of those above 65 have some degree of MCI. So why it's important? The MCI can be screened by a variety of MCI indexes. It's just a simple questionnaire. So what happens if you actively screen these things that may not be clinically apparent is so that you can predict and prepare patients and caregivers for the likelihood of post-operative delirium. And of course, if you read the original paper that we wrote, you realize MCI and dementia, when you pick it up, post-anesthesia, their memory can also be affected. So you now have a tool on hand to actually predict these things. So as we said, preoperatively, you should now screen for MCI and dementia, but dementia should be more obvious. MCI should be screened so that you know these patients post-op, they may go confused and all that. And therefore comes recommendation 5. Frail older patients should be screened actively, post-operatively for signs of delirium and treated as soon as you can and aggressively. And again, I admit in my clinical practice, we don't do that. Many a times when the patient's obviously delirious, seeing things that aren't there, totally confused, then we realize, he's delirious. Which shouldn't be the case, right? We should be actively screening and preventing it. So that begs the question of delirium. So delirium occurs in about 50% of those above 65 post-operatively. The challenge is delirium. We are very used to picking up the hyperactive delirium, screaming, shouting, pulling out catheters. We are used to seeing that. How about the hypoactive deliriums, the ones that you can't detect? And it's therefore unrecognized in about 2/3 of post-operative delirium cases. Now, this is severe. This is very high. And we know that delirium, when it sets in, it's associated with functional cognitive decline, increased morbidity and mortality. I mean, all of us have got experience. Patients come in so well, after emergency surgery, go ICU, come back, somehow they land on a nursing home and they just never get back. Right? We have all this experience because of all these issues. We're not actively catching and making interventions. So screening actively, okay, there's a lot of methods you can do. Post-operatively, there's a confusion assessment method. You can engage geriatrics early. And most important thing is point 3, if you can see my mouse, 50% of delirium cases are preventable by a post-operative delirium bundle. And this bundle could be just simply looking through the medicines, removing psychotropic drugs, increasing caregiver support, orientation of time, places. In my hospital, we even have a chart. Basically, we have a room where we cut off stimulation, but you try to get the timing like, it's sunlight, you let sunlight come in, they get oriented to time. We even put pictures of the Prime Minister, propaganda there to help them reorientate. Okay, so these are things that we can do actively. So recommendation 6 is that overall, frail patients benefit from a multidisciplinary approach, which includes a geriatrician. Very simple, very logical, but it's not actively practiced. I mean, come on, how many of us in our routine rounds has got a geriatrician falling around? So why a geriatrician? Apart from the fact that, hey, it's your specialty, there's evidence for this as well. Geriatricians, various studies have proven they're obviously good at managing geriatric syndromes, the dementia, the falling, the polypharmacy, and it is also proven to be commonly underused. But many times it is simply because the hospital don't have enough resources. The geriatricians are so busy, they can't be following the general surgery rounds, colorectal rounds, oncology rounds, orthopedic rounds, they can't. So there are, of course, other papers that provide solutions. We need to train a team of specialists who can do what geriatricians do, including using registered nurses and things like that. And there have been studies, and I draw attention to Shahrokhi. Shahrokhi's studied 1,000 patients undergoing cancer surgery and compared this with 800 patients who were treated with standard management, meaning no geriatrician. And lo and behold, those with a geriatrician on board, their probability of death was halved. half. So really, this paper is one of the most cited papers to say that we need to have better supportive care services. And of course, if there's geriatricians who hear this, they're going to groan, right? Because there's just not enough of them. Other studies have also shown, even in the elective setting, 300 patients above 70 years old, when they're assigned to the usual care versus a multidisciplinary geriatrician-centric care, there's a lower incidence of geriatric-related complications. Delirium is half. Geriatric syndromes are half. And we know this is not just about the patient being confused after that, right? That has a real impact on outcome. And again, NELA audit. Again, NELA and ELF are probably one of the most quoted now in these recent times. Any clinical guidelines in any country always quotes them because they're big and they're recent. So NELA audit also showed that basically the, oops, is there someone? Let me see. Okay, sorry. Maybe there's a question. I'll answer this later, I guess. Okay, sorry about that. Okay, so for the NELA audit, so just give me a while. I just want to close this because it's blocking my screen, the Q&A. Okay. Okay, great. So basically NELA audit, just the key of this I wanted to show you, sorry about that, was that basically the most important thing about the NELA audit is that for the first time, at least in documented history and transparently, the United Kingdom has actively taken measures to implement the NELA audit to make geriatricians become part of the system. How they do it? Well, it's beyond the scope of this topic, but really it's about money, right? It's like you don't have them, you don't have certain things, improvements in hospital, I'm not giving you money. And well, outcomes have improved or are improving. So recommendation 7, older patients should be screened actively for social vulnerability and offered support. This is very interesting. And this is something that applies to me as well. We usually don't do it. We usually wait when the patients are recovered and we want to discharge home. Then the children or the family will say, I can't take them home. You know, I need to put them in a step-down care, a community hospital, and all that, right? So basically, no, we cannot be so passive. We need to actively screen and do something about it. So this is a new concept called social frailty, where basically means is that the risk of losing resources, losing support for these old patients. And we know that because, oh, you could be alone, your spouse could have passed on and so on and so forth. Children may leave you alone. And there's no real study on emergency laparotomy in this case, but you know, they studied things like amputations and show that actually if you introduce social integration, you think about the post-operative care. Will the patient have friends? Will the patient have community support? And outcomes improve, quality of life especially. So again, there's a prospective study of 900 patients undergoing colorectal cancer resection and show that if you help the patients have social support, easier said than done, the psychological distress and quality of life improves dramatically. And it really makes a difference to them, right? We know this. Of course, we never had evidence for it, and evidence is coming up. So it's something we should always consider. And we don't really ask that. We don't ask the patients after discharge, who's looking after you? Do you have enough support? What network? We need to do all these things. Okay, so recommendation 8 talks about ERAS, or enhanced recovery after surgery. And of course, in the emergency laparotomy setting, we are recommending that ERAS should also be instituted in some capacity. And let's move into that. ERAS. ERAS has largely been applied to the elective surgery setting, but there's evidence, and logically so, that even high-risk surgical patients undergoing emergency laparotomy can also benefit from ERAS. This is something that is very understandable. But of course, we also know, those who practice emergency surgery, that ERAS is not easy to implement because the patients are really high risk, the conditions are variable, you can't really have a standardized way of recovery. But the evidence is showing. So really, unlike elective surgeries, ERAS does not have very clear pathways and protocols yet in general surgery, emergency general surgery, partly because the patients come all shape and sizes and all kinds of physiological states. But we should consider it. And if not having a protocol, at least the principles of ERAS should apply. Early mobilization, removing catheter early, and so on and so forth. Recommendation 9 suggests that minimally invasive techniques should be considered where possible. Again, the benefits of MIS, very basic. It's proven to have decreased morbidity, shorter length of stay, less postoperative pain, less postoperative pneumonia, faster resumption of diet because of left eyelids and so forth, reduced wound infection rates, etc. These are very generic benefits. And Prof. Katena and some of the doctors at Bufali are now working on a new paper to actually show this, and you might see this paper coming out soon. Our MIS emergency surgery. But as you can imagine, despite MIS logically being fantastic with a lot of benefits, the uptake is still pretty much low. Maybe the technology hasn't improved enough, we don't know. But we know for a fact that laparoscopic appendectomy, lap chole, lap repair of gastroduodenal ulcers, we know now everyone accepts MIS is the way to go. But as we can see, even from the UK, less than 20% of surgeries are still performed laparoscopically. And this also comes from the US studies, it's all about the same. So why? So the WSCS emergency survey basically asks WSCS members what some of the reasons that we can, consider improving these metrics. So people believe that, of course, with longer personal experience, constant use of laparoscopic elective surgery, expertise in bariatric, all this gives the surgeon confidence to use MIS approach, even in emergency setting. But of course, we still have a lot of work to do to prove these benefits beyond just appendix, chole, and gastroduodenal ulcers to ischemic bowel, so on and so forth, incarcerated hernias. And of course, even having the evidence, there's still another step to go, which is to give the surgeons the training, experience, and confidence to apply these skills. But that's a whole different topic for another day. Recommendation 10, again, in older patients, frail patients rather, they must have very specific discharge planning and post-operative functional outcome planning. This is something that we don't think about much, right? From the surgeon, operate, never die, can go home, fantastic. But we that's not the case, especially for maybe Italy, I see a lot of them going home. But in the Asian countries, in Singapore, for example, a lot of them always want to go to a smaller hospital. We call it a community hospital for rehabilitation and so on and so forth. So all these things need to be planned actively. We shouldn't be in a position where, all right, sir, today you're going home, and then they tell us they want to go to these places. So if we plan it and from the start, and the pathway is clear, their outcomes are always going to get better. Why? One thing is also very important is that we are not at the age yet, most of us, but you can imagine you are now frail, 80 years old, you're going to go through emergency laparotomy, you're alone. You would want to know what your discharge planning is like, because it's been proven through various studies that when you interview these frail older patients, a lot of them are more concerned about the anticipated disability and the loss of independence after surgery, even if the surgery means saving their life. And they're more concerned about that rather than whether they survive through this cancer diagnosis or surgery. You see, and there are many tools out there to be able to assess this and counsel the patients. It's really important. Recommendation 11, at the end of the day, this is just a very simple topic. And basically, we are at the cusp of, we are recommending various steps to improve how we handle these patients. But really at the day, adoption of a holistic CGA-based system around the world, especially in developed countries, so it's still very much dismal. Uptake is still very poor. Developing countries, I think, is going to be even worse. And a lot of efforts needs to be taken up. It's easier said than done because it needs resources. It needs hiring more geriatricians. It needs more interventions, more time, more resources. So the uptake is still abysmal. And we hope this can improve. And that's why the NILA audit is so important, because the NILA audit is, the government is actually acting on it to try and hit these new targets. Recommendation 12 is that we bear in mind, we've been talking about frailty, how to screen, understanding its importance, and other things we need to actively do for frail patients. We must also consider there's a very special group which is patients above 90 years old, where basically the frailty index is just one aspect of their assessment, because overall, apart from morbidity, mortality being high, crucially in today's context, unless we invent something unusual in the future, natural lifespan is already limited, right? In 90 years old, you're exceeding the average lifespan. So at the end of the day, no matter what you do, for those above 90, they may just still die. So Pulaski shows that 30% mortality rate for those above 90, no matter what you do, it's already 35%. Of course, Hoskin and Sudlow show slightly lower numbers, but Sudlow very importantly showed that almost half of patients will still die within 30 days. And it rises even up to 1 year. So at the day, for this above 90 years old, it's quite tricky, because this was an England study. They somehow quoted that on average, even then, you can't live more than 4 or 5 years after surgery. So we bear in mind that this is a very special category, and the counseling and the discussion has to be different. Because again, maybe it's just kinder to take a more conservative path. And that represents the end of my talk. Thank you very much.
Thank you, Brian. Thank you for your presentation. There is some one question in the chat. You can read it about confusion in emergency elderly patient. How you can assess it if you have to differentiate confusion and dementia. How you can do this?
That's why you need a geriatrician. But ultimately, in the normal rounds,
you don't have a geriatrician, so you have.
Yeah, so absolutely right, which is why I mean, I'll be honest with you. For us also in my practice, usually when the patient's obviously got nuts, obviously demented, seeing ghosts, seeing things under there, then we realize it's dementia. It's very hard to detect, which is why, and remember, bear in mind, as I mentioned, a lot of it is still hyperactive delirium. The hypoactive delirium, quiet, nice patient, very quiet, those are the kinds that go missing.
Okay,
so
you can suggest a tool for practice.
Okay, so the answer for dementia is that it is very difficult. There are many tools out there. I can forward to you. There's a whole list. To be honest, for us, right, there is basically a scoring system. There's a cognitive scoring system upon 30. You can use or some people use the MMI. The MMI is another easy one, just a 10-item scale. Usually can ask the junior doctors to apply. And that's how we can detect things like all this cognitive impairment. As of now, there are many different tools.
The problem is always the same. You can assess confusion because geriatric patient, I don't know what you intend, what you mean about geriatric patient in emergency surgery, because in your presentation, there is not a definition of age, but you agree with me that your patient is, your elderly patient is often confusion because the intraabdominal infection. So how you can do the difference between confusion and dementia? Dementia, you can assess dementia after the surgical intervention, but when you admit your patient, how you can do this?
So this one, to answer your question, I'm going to be very transparent. The paper, we did not address that specific details. So this will come from me anecdotally because I can't speak for everyone. And the paper, we did not focus on that. But in my institution, in my practice, what we do is this. If we suspect a patient is demented, hyper or hypo, what we do is we do a quick AMS testing, orientation to TPP, time, place, and person. I'm sure you use that. What's the time now, morning, afternoon? What place are you in? Are you in a hospital? I mean, we cannot say that. Where are you? And who is the Prime Minister of Singapore or Queen of England, for example, depending on where you are. And that's how we detect very fast whether the patient is there or not. Next, once the patient is confused and clearly cannot answer, for us, what we do is we usually do two things. One, investigation. Two, we have geriatricians because we are a tertiary hospital. So geriatricians always get on board. But for this, the basic test we always do is the full blood markers, septic markers, the vitamin C, B, and all that. And basically try to figure out is what's driving this. And then we do a scan of the brain, usually a CT, CAVI, MRI, because it can be anything from sepsis to stroke, to so many things that contribute to a AMS, altered mental state, which is not dementia, right? But AMS is delirium. So you are dealing with a delirious patient. But the dementia can only be detected after the delirium episode is over. Then you can assess whether it's demented or not. This is when you don't realize that you got a patient like that, which is why the paper recommends you shouldn't be in a category. You shouldn't be in a category where the patient is confused and you're like, okay, there's delirium, we accept that. Was there dementia? We shouldn't be like, oh no, how come we don't know? We should, from the start, already have done the MCI testing and said, hey, this patient's at risk of delirium, and maybe there's undiagnosed dementia. So those are quite different things. So when we say confusion here, in my setting, we're talking about AMS or altered mental state, or i.e. delirium, essentially. And dementia is an underlying thing.
So the recommendation is to assess as soon as possible this dementia, because it's not possible in the early phase of assessment,
phase, no.
but you can do this after. So the emergency surgeon can do this. Okay, what about the rate of laparotomies for elderly people? Because you focus on laparotomies, but how many patients are submitted to undergone to laparotomies in emergency setting? Do you have the data?
No, I'm sorry, I don't have the data.
Okay. If you can compare your paper with the NELA audit, which are the difference between your works, our works, and the NELA audit?
Well, actually, it's quite similar because we borrow a lot of topics from ELF and ELA, which is quite similar. But one of the key differences is, I would say, that most important is on the concept of the screening and then the comprehensive assessment. Because the screening is the CFS score, the NELA uses above 5, which is already considered to be frail. If you see a lot of the other studies out there, people use 4, which is vulnerable, and they start all these bundles in screening already. And then when we talk about the comprehensive assessment, there's a whole different discussion out there. Because the NELA CGA, I can't recite all the numbers right now, but if you see it, it's on the 6 things, the ADLs and all that. And basically, they use that, but that's again not necessarily the gold standard, in the sense that every institution uses a different kind of CGA, and some people use CGA in a different setting. So I can give you as other further examples. There are a lot of papers out there. If you read papers from oncology perspective, they will quote ECOG, right? ECOG score as the big screening, not frailty, they quote ECOG. So that's the one restriction on NELA, is that CFS is not necessarily the most important and prevalent, but because in terms of current evidence, I would say that the NELA and ELF are the biggest, most important right now. That's why we follow based on the current evidence.
So, okay, thank you. Last question. If you don't have a jurisdiction with you, how emergency surgeon and anesthesiology can assess frailty in the emergency setting? Well,
so based on the current evidence, you got to use the CFS score, which is, if I can show you the slide, it's not hard to imply. And I'm just sharing from my own experience. We start to do this, but usually we let the nurses and the junior doctors plug them in. So the nurses usually go in, they assess some of the basic things as part of the clerking process or admitting process that the CFS produced there. But to be frank, in my own institution, the CGA is never done because it's just too intense, yeah, unfortunately.
Okay,
so
thank you very much. Thank you very much for your presentation.
Thank you.
Very interesting. Okay.
I'm sorry for interrupting, Dr. Brian. You have a question in the Q&A box. Can you see the question?
Yeah,
I think it's just a comment, rather.
I did it. I read it.
Oh,
and
okay.
Yeah, and it's more like
proceed.
a comment.
Thank you, Brian. So we can move on the next speaker, Professor Cadena. Okay, I will introduce.
You can introduce it.
Okay, I will introduce Dr. Carlo Vallicelli. Sorry, and I have to find my Dr. Vallicelli, that is a collaborator of Professor Catena. So he's working at the Level 1 Trauma Center, Maurizio Bufalini Hospital in Cesena, Italy. He's a general surgeon. He's an experienced laparoscopic surgeon dedicated to laparoscopic colorectal surgery, laparoscopic abdominal wall surgery, laparoscopic emergency surgery. He's a senior surgeon of the trauma team. He's author of and co-author of several peer-reviewed articles and book chapters. And Professor Catena invited him to talk about futility in emergency surgery. The stage is yours.
Thank you, Belinda. Good morning, everybody. Can you hear me?
Yes.
So talking about futility issue, a big problem in our clinical practice. I would start with the definition of futility. So what do we mean by futility in surgery? It's really difficult to define. So the concept of futility is having a goal, carrying out actions and activities aimed at achieving that goal, but with the virtual certainty that we are going to fail. And we have two concepts inside the futility. So we have the quantitative concept, that is the statistical probability of surviving a specific procedure or having success with the treatment. But we have a qualitative concept of futility as well. So that is the benefit that the procedure may bring in terms of quality of life, for instance, in having a stoma, or if we need palliation in the oncology setting. So the concept is pretty challenging, And it's challenging indeed in our clinical practice. As we know, we need to put together the qualitative concept of futility, the quantitative concept of futility. We have to evaluate the geriatric patient, perform an MDT discussion, stratify the risks of our surgery, and that is the decision-making process that, as we know, it's really a challenging process. We have some parameters that can help us in predicting the futility of a surgery. So advanced age, the serum lactate level, renal function, patient comorbidities, the state of consciousness of the patient, and the presence of sepsis or septic shock. Moreover, when we face a geriatric patient and older adults, we also have to deal with the relatives and with the caregivers. And that is an important topic, since as surgeons, we are very focused on the quantitative aspect of futility. So we want to know that our surgery is going to succeed, the patient is going home. But maybe for the family, for the caregivers, the qualitative concept of futility is the most important one. So having a stoma, being discharged with the need of presides, these are all important things for the family, and probably these are the most important in their point of view. The concept of futility is strictly related with the concept of frailty. You already mentioned frailty in the previous lectures, so I will be brief. We know that conventionally geriatric age starts at 65 years, at 65 years old, and we know that aging is an inevitable and irreversible organ decline with years. So the patient has a reduced ability to maintain homeostasis under stress. We know that frailty has a linear, do not univocal trend with age. So we have a 10 to 20% of frail patients over 65 years old, but this rate is increased towards 40% over 80 years old. How can we evaluate a geriatric patient? We have, in the preoperative setting, we have several scores. Of course, the ESA scores is useful, and it's useful to try to define how the patient is fit for a procedure. It is subjective at the same time, and can give us some important information about mortality, but not at all about the possible complication that the procedure is going to bring. We have the Apache 2 score. This is often used in the ICU setting to define the degree of the pathology in the first 24 hours of ICU hospitalization, but it's really laborious to perform, so not that easy in the emergency surgical setting. We have the clinical frailty scale, as we already mentioned, so it can be useful because it's specific to the older adults. We divide the population of interest into 9 different groups based on comorbidities, physical activity, autonomy in the activities of daily living. Again, we can have an idea of the mortality rate, but we do not have a prediction of the short-term surgical complications. This is the American College of Surgery online risk calculator. It's pretty interesting, in my opinion, very quick, very easy. It takes into account both the patient condition, so age, comorbidities, drug use, lifestyle, so if the patient is a smoker, is a drinker, and the type of surgery that we plan. It's very interesting. You can enter also, if the patient is a geriatric patient, you can enter also information about the level of autonomy of the patient. And in the end, we have a risk stratification about mortality, but also about medical complications, surgical complication, risk of institutionalization. So very interesting for the risk stratification, in my opinion. And this is the pre-possum score, validated, often used in the clinical practice. So we have evaluation of physiological parameters, operative parameters, and in the end, we have a stratification risk both for mortality and morbidity as well. As Brian already said, the comprehensive geriatric assessment is of utmost importance, and ideally every geriatric patient undergoing surgery should receive a CGA. Not always possible, as we said in the clinical practice, but really important, evaluating age, comorbidities, the autonomy and activities of daily living, The CGA evaluates the psychological, cognitive, and social status and the family support, and it should provide not only the risks strictly related to surgery, but ideally it should also organize a postoperative recovery. So it should target a physiotherapy program for the patient. It should ideally plan discharge, so we shall know if the patient is supposed to be discharged home or with care facilities, and should guide family members and caregivers, for instance, in organizing presides or assistance after the discharge. Several figures are involved in the CGA, so the geriatrician, of course, is the cornerstone of the CGA, but also the case manager nurse and the social work. But if we perform a CGA aimed at surgery for a geriatric patient to define the futility of that procedure, the surgeon should be involved as well, in my opinion. We know that the concept of futility in surgery is strictly related to the concept of frailty. We already discussed about frailty. It's a reduced physiological reserve that is associated with increased vulnerability, and it's due to a loss of physical, cognitive, social, and psychological functioning. So we have an increased susceptibility to adverse events, disability, and death. As Brian showed, with frailty in the surgical setting, literature says that we have an increase of surgical complications, of medical complications. We have an increased length of stay and institutionalization rate, and we have an increase in postoperative disability and mortality. So this is really a big issue. And it is really different to assess frailty. In surgery, we have several scores. We have almost 50 scores. So from the frailty index, we move to the modified frailty index 11, the modified frailty index 5. We have the dedicated scores for trauma and for emergency surgery. So it's not clear which one is the best. And defining frailty in the surgery setting is a real challenge for the CGA and for the MDT that is involved in evaluating the futility of the procedure. So talking about futility issue, in my opinion, we need to distinguish two settings. We have the elective setting and the emergency setting. In the elective setting, we have time enough. We can provide an accurate assessment of frailty and of futility of the procedure. And we can involve all the different specialties that shall evaluate the geriatric patient. This is a proposal of preclinical evaluation of the patient in the geriatric oncology practice. In this flow chart, we have the physician assessment. So both the geriatrician and the oncology are involved. We have the audiology assessment, the pharmacy assessment, the physical therapy assessment, the case management assessment, nutrition assessment, nursing assessment. So different figures should be involved in evaluating frailty and futility. Ideally, the team should work together. This figure should be strictly relating in evaluating the patient in a one-time setting, and should provide a summary of assessment and should educate the patient, the family, the caregivers, and should implement the plan for the geriatric patient. Of course, this is an ideal situation. This is an overview of the multidisciplinary clinics in geriatric oncology in the US. It's really challenging to have all these figures that can be present for every single patient. But ideally, this is the goal that we shall aim at for the elective setting. Because we do know that the comprehensive geriatric assessment can predict postoperative complications in gastrointestinal cancer patients. This is a meta-analysis. We have 6 core studies, mostly involving colorectal and gastric cancer patients. So we can see from this meta-analysis that the comorbidities, a Charlson comorbidity index of 3 or more, together with the polypharmacotherapy and the dependencies that autonomy of daily living, they all increase the risk of 30-day postoperative major complication for the geriatric patients undergoing surgery. So we have probably time enough in the elective setting to define accurately the futility of the procedure. The situation is a bit more challenging when we face the emergency surgery patient, This is an increasing issue in our clinical practice. We do know that in the last 10 years, we had an increase in the emergency department visits for older adults by 30%. We do know that patients over 60, they represent over 30% of all the emergency general surgery cases. Generally speaking, in the emergency general surgery setting, we have an increase in the mortality rate. It is 5 times higher as compared to the elective setting. We have an increase in postoperative complication. This is 3 times higher. So we should think that this increased complication rate is related to this particular population of geriatric patients. And we know that after 70, the death after emergency laparotomy is doubled. So this is a big issue. The emergency setting is really a big issue. We know that frailty in the emergency general surgery setting is strictly related to mortality. So, and to all the postoperative outcomes of the surgery. So an accurate assessment of frailty is ideal even in the emergency setting to define what futility of surgery is. And this is a raising problem, as we said, and a really cause of concern. We see, this is an interesting study, we see that by increasing frailty, this is measured by the MFI-5 score, by increasing frailty in the emergency general surgery, we have an increase of any complication, an increase in the failure to rescue surgery, an increase of the reoperation rate, and increase of the all-cause mortality. So really, really a big issue and a challenging definition of futility. Frailty assessment is not often easy in the emergency settings, and sometimes we miss this assessment in our clinical practice. But as we can see, by increasing the compliance of the frailty assessment, we can have a reduction of the in-hospital complications for our geriatric patients. So the frailty assessment importance, even in the emergency setting, should be stressed. Sometimes it's challenging, sometimes it's almost impossible. Sometimes it's difficult to communicate with the patient because of the state of consciousness. Sometimes it's difficult to communicate with the relatives as well. We cannot find the relatives. We do not have time enough to talk to them. So sometimes it's really difficult to use the available scores. And that is the reason why the frailty basing concept was developed so we can investigate frailty from the CT scan of the patient. We can evaluate the sarcopenia with the total psoas index. We can define the osteopenia, evaluating the ROI of the anterior vertebral trabecular area at L3. We can evaluate the sarcopenic obesity, the renal volume, the normalized for the patient eye. We can evaluate the calcification rate of the abdominal aorta. So this can be an alternative measure of frailty in the emergency setting. The problem is so important that we have dedicated guidelines for the geriatric population in the emergency setting. This is the 2017 WSCS and SICG joint guidelines for the acute calculus cholecystitis in the elderly population. Dramatic problem. Daily clinical practice cholecystitis in the elderly. So really difficult to define what futility is in this setting. And interesting in the guidelines, we know that from the guidelines, we know that cholecystectomy is still the preferred treatment also in the elderly. We do know that laparoscopy is the ideal treatment, that early cholecystectomy is the best, but guidelines say accurately evaluate your patient, assess frailty, define what futility is at the best as you can, because you also have alternative treatment. You have the percutaneous cholecystostomy, you have antibiotic treatment, some new endoscopic approaches are emerging. So the definition of frailty, the definition of futility is really of utmost importance even in the emergency setting. And let's think, for instance, of the big problem of the complicated colorectal cancer. What to do with the geriatric patient? We have several strategies that can be put in practice. So we can have a resection, a palliative resection. We can divert the patient. We can put a stent. So a multidisciplinary evaluation, even in the emergency setting, really should be mandatory in these patients. So the issues the futility issues are several. How can we solve this problem? What can be a problem-solving strategy? Let's stress the concept that CGA is important, that the MDT is important, involving as much specialties as possible. Maybe, especially in the emergency setting, when we don't have time enough to involve all the specialties, maybe we should evolve towards the concept of a geriatric surgeon and a surgical geriatrician. These two figures in the future, maybe they shall be strictly related to evaluate the geriatric patients and to proceed with the decision-making process and to obtain a patient-tailored approach on a case-by-case basis. This is really a big challenge, and this is a big challenge, especially in the emergency setting. So, especially in the emergency, the answer is always the same: emergency general surgery organization. This is the key to improve the patient outcome, to create dedicated pathways for this patient, to involve skilled physicians dedicated to this particular population, and in the end to reduce the morbidity and the mortality of our geriatric patients. I really want to thank you for your attention.
Thank you, Carlo, for your presentation. It was not easy to collect all the data because there are a lot of literature, but focused on the elective setting, and emergency is always a big problem for us with the heavy responsibility. What I have to say that we can change the setting and we can change the patient, because futility is correlated with a surgical procedure or management of a patient with severe comorbidities and severe injuries. So we can change our practice. You talk about the focus guideline. What do you suggest in the practice of the emergency surgery, in the intent of rescue a patient? What we can manage an elderly patient to avoid futility?
Thank you for your question. It's really difficult to make suggestions. This is, I think, one of the most challenging aspects of our practice. So when you're dealing with a geriatric patient in the emergency department, you know that you need to go for surgery, and sometimes you do not have time. You need to decide. You cannot wait for the following day. You cannot wait for the geriatrician to evaluate the patient. This is challenging. We have the scores. We have some tools, but sometimes, as you previously said with Brian as well, sometimes the state of consciousness is alterated. So, and you don't even know if the patient has a chronic dementia or is the abdominal infection that is altering the consciousness of the patient. In this case, evaluating futility is really challenging. That's the reason why I try to propose a geriatric surgeon. So a surgeon that is used to deal with these patients also in the elective setting, or if you have an urgency that can be approached within 48 to 72 hours, that is used to closely work with your geriatrician, and the geriatrician should be skilled in surgery as well. So this kind of team building maybe can help you even in the case you mentioned. So when you do not have time enough to accurately evaluate the frailty of the patient, and you need to decide whether surgery is futile or not. But again, I think this is one of the most challenging aspects of our clinical practice. So difficult to make a strong recommendation, and I really appreciate the effort of the WSUS to try to help clinicians in this challenging setting.
Okay, So the message that we have to pass is that the emergency surgeon and the anesthesiology have an important role in managing elderly patient in the emergency setting. So we have to have the skill to manage the patient, to have the knowledge of the aging of physiology, and to learn to share our decision with the family and to consider the patient the size. This is most important for the emergency setting, where the mortality rate is quite high for our practice. So focused guideline, knowledge of physiology, and a small team including emergency surgeon and anesthesiologist to evaluate the patient. Okay, there is no question for you, so your presentation was very clear. Thank you, Carlo. We can introduce the next speaker, that is Raffaele Bova. Dr. Raffaele Bova is another collaborator of Professor Catena. He's working in the one-level trauma center in Bufalini Hospital, Cesena, Italy. Raffaele is graduated at La Sapienza University in Rome, and completed his fellowship in general surgery at Bologna University, alma mater. During his training, I think that we have to close some microphone, please. During his training, he has been devoted mainly to emergency and trauma surgery, attending several departments, and then he chose Professor Catena. So let's start with your presentation, please. Nice to meet you, Raffaele.
Nice to meet you, Belinda. I'm Dr. Raffaele Bova. I'm using the Dr. Carlo Valicelli tablet for some connection problems. Thank you for hosting me today. My colleagues have already extensively discussed the problem of frailty in the elderly people and the challenge of surgery for these patients. Today, I will speak. Today, I will speak about the protocol of a new study we're intended to carry on, the Aperol study. Our idea is to conduct prospective multi-center observational study on over 90 years patients who came to emergency department with a surgical problem, with acute secondary peritonitis. The aim of trial is to observe the early and late outcome of patients undergoing surgery or non-operative treatment, and assess the tools we can use in the choice of the best treatment. Why do we want to focus on patients over 90? Here there are many reasons. We looked at the growing number of oldest patients who came to emergency department with surgical disease requiring surgical treatment. But as widely known, increasing age is an independent predictive factor of post-operative morbidity and mortality. Elective emergency abdominal surgery are featured by higher risk procedure to carry on with respect to younger patients. Despite there is a huge variation in individual health status, over 90 people more often have multiple comorbidities, need of polytherapies, and present a vulnerable status defined frailty. So it's very difficult to establish which patients benefit from being treated with surgery. We don't forget that nearly 50% of non-Agenarians patients underwent emergency surgery die within 1 year after surgery. Moreover, we must point out the impact of surgery on worsening of the performance status, the quality of residual life, and the considerable use of resources to treat these patients as well. A stratification of perioperative risk appears useful, and the decision-making process can be supported by the use of most common scoring system used also in elective surgery. Currently, the majority of studies are performed in elective on younger patients, while few studies describe the outcome of non-Nigerians underwent emergency abdominal surgery, and they are mainly retrospective studies. As described by Portinari et al., and in the observational study of Pelaschi on non-traumatic patients, there is a quick decline in survival of the first 30 postoperative days, and most of patients experienced medical complications after surgery. Similarly, Peregard et al. And Raps et al. Found that emergency surgery in non-Nigerians is a high-risk procedure with high short and late-term mortality, with an overall mortality which raises to 50–54% within the first year. Thus, it would be desirable to assess the real impact of surgery and benefits on long-term outcome of these patients, and find out easily obtainable factors which best predict mortality and mortality. So, the primary aim of the study is to assess the early and late outcome in patients 90 years old age with acute peritonitis, subject to surgery and non-operative management, with focus on 30-day, 1-year survival rates, clinical course and post-operative complications rate, 1-year functional status. The secondary goal of the trial is to investigate which factors can contribute in the choice of non-operative management instead surgical intervention, and assess the accuracy of most common risk scoring systems in predict poor outcome. The APEROL study would be a multi-center prospective observational study. The promoter is Professor Dr. Fausto Catena from the Maurizio Bufalini Hospital in Cesena, which results as the coordinator center. The study design provides a 1-month patient enrollment time, and then the collection of admission, 30 days, and 12 months patient data. APEROL is a non-profit study, and the principal investigators have to see absence of conflict of interest, the collection of informed consent to all able patients, and if not, to their family or caregivers. Our target population consists of all consecutive 90 years old age patients or older ones that are admitted to surgical department for acute secondary peritonitis and are going to surgery or non-operative management for 30 days enrollment period. According to literature, emergency surgery in non-Nigerians is a high-risk procedure with high short mortality. So the estimated overall 30-day mortality after surgery to each participating center is of 31–35%. So we expect the inclusion of 100 patients treated with surgery for acute peritonitis should be a sufficient sample to analyze study objectives. For the selection of patients, inclusion and exclusion criteria will be applied, and all participating centers are provided with the study protocol and other relevant study documents, so they can request for approval according to local ethical protocols. APEROL foresees the collection of primary and secondary outcome parameters. So the relevant data will be analyzed regarding number of non-Nigerians enrolled in 1 month, patient characteristics, and the status of hospital admission, etiology of secondary acute peritonitis, scores for risk prediction, type of treatment, surgical and operative treatment, and so there will be collected follow-up data regarding in-hospital course, post-operative complications, 30-day early morbidity and mortality, 12-month late morbidity and mortality, 1-year functional status, and living situation. Data will be collected using REDCap web application, and a detailed CRF is created from REDCap database and provided to the invited centers. When meta-analysis performance of relevant parameters and factors that are considered to be clinically relevant are selected for multivariate analysis. Survival analysis carried out generating Kaplan-Meier survival plot, and selection is used to exclude the values of P measured 0.05 from the model. So we will present study findings at the end of trial. Thank you.
Okay, thank you, Raffaele, for this interesting study that we will launch soon. There is no question from the audience, but I have a question for you because I'm very interested in the managing of non-Algerian patients, and I proposed to you a study at the last year. It was quite on the same line. So I have a question.
Yes.
How you can define, how you can limit the bias of selection of this patient? Because non-Algerian patient, you have to consider an expectancy of life. They are not islanders. So how you can limit the bias of age in this cohort of patient, how you can limit the harmful of the emergency surgical procedure?
It's an interesting question. I think that analyzing primary and secondary parameters, we can find the best factors that we can use as tool to select patients for surgeon operative treatment.
Yes,
So
but
I think,
study is a prospective, so you will select the patient, no?
yes, yes.
You have a criteria, an inclusion criteria. So all the patients that will submit to an emergency surgical procedure will be age over 90, will be
Yes.
able to be included in the study. But how
Yes.
you can limit the bias of age in this group of patients? Because a 90 patient can die because life is ended. So how you can say that your procedure is futile? But it's only a suggestion. It's not. It's only to
Yes,
talk.
yes. I think that there's this is not a bias, because if we can find that the futility or not of surgery for these patients, the survival within 1 year is a tool we can use to establish if the treatment is or not useful for patients. I don't know if
so
your
main aim, the main aim of your study is what? What do you want to assess? What do you want to show?
We want to assess if the patients undergo surgery at 1 year, present different outcome from patients treated non-operative management. So if the real useful surgery for these patients or not.
Okay. Professor Cadena, do you want to add something because you are the main coordinator of the study?
Well, I think everything is clear, and maybe we can wrap up because it is 11:51. I think that this webinar was very interesting. In the different lectures that you listened to, we had a lot of take-home messages and a lot of new points of view about our present and future work. In the first lecture, we had a very great overview about trauma, geriatric trauma, and you saw that it is a totally different field, and it is a very particular population. So, as we learned for pediatric trauma, maybe now we have to think also that geriatric trauma is a sort of different special population that needs special recommendation and guidelines. In the second lecture by Dr. Tian, we understand that the problem is not only from the age, but you have to think about the frailty. And you have to think also about your capacity to diagnose and to assess a frailty. And when you are able to diagnose, to assess that you have in front of you a frail patient, so you have to start immediately with all the strategies to improve your action. And you have to do it in acute care surgery setting, so it is not so easy. And this is another different point of view. And we can say it is the same for the ERS protocol. When we started elective surgery with ERS protocol, we started to think differently in the approach of our patients. And maybe it's time to do the same in an emergency setting with the frail people. In the third lecture by Dr. Valicelli, another strong issue came to our attention. It is about futility. We have to treat this patient, but we have to know when to stop. And it is very difficult, in some cases, to understand it. It is very difficult to decide to do it, and it is very difficult to do it. But again, if we are prepared, we are organized, we can start to do it. And again, we have to start to understand that this is a fundamental pillar of managing all patients, geriatric people. Finally, the last lecture by Dr. Boa, it is about a very challenging trial. It's a trial that wants to understand which are up to now the best practice in geriatric people management. We need a lot of these trials. We need a lot of research in this field. And up to now, this research was not so performed. And we hope that with this webinar, with other many initiatives that we had and we have, some of them involved in Journal of Clinical Medicine, we can push research on this very important and challenging field. I want to give you the speech to Dr. De Simone for the last words. Thank you very much for inviting me. It was a pleasure and it was an honor to be with you here today.
If there are no further questions, I want to take this opportunity to thank all speakers and participants for attending this webinar. We hope you gained some inspiration from today's talk, and we look forward to meeting you in the next webinar. So thank you again and take care.
Bye.
Goodbye.